There we go. Great. Great. So shall we make a start? And other people may be joining us because, we're all kind of fitting this in a sort of lunch break, I think. So, so we've got 30 minutes with Rebecca Salama. Thank you, Rebecca, for coming to share your work with us. We'll have about 30 minutes hearing from Rebecca, and then we'll have an opportunity to meet together in smaller groups, sort of 25 minutes in kind of breakout rooms. We've got a few questions just to kind of get those discussions sort of kicked off. And then we'll have 30 minutes kind of meeting together for questions and answer, kind of plenary discussion in the wider group. And again, just a reminder, if you'd like to mute, if you're in a busy office, that can be helpful. So a little bit about Rebecca Salama. So Becks has an MA in social work and has been interested in complex mental health needs at the end of life for some time. She was a palliative care social worker at Princess Alice Hospice in Esher and identified a need for a stronger trauma-informed approach, and developed a psychologically informed consultation training as part of the hospice's Diversion and Inclusion program. And this program went on to support people who are homeless, prisoners, and those with drug and alcohol addiction. She can move her involvement in research and academia, and she previously joined a team of 2 professors at Kingston University to complete a qualitative research project, and that was on approved mental capacity practitioner role and liberty protection safeguards. And they published a paper entitled "How Can the Palliative Care Perspectives of LGBT+ individuals, their carers and their healthcare providers help UK hospice teams confront and resolve issues of inequality and inclusion." So she's here today to share with her PhD research to map the potential for trauma-informed care for people referred to palliative care services. So this was a project that was, have I got that right? Yeah, yep. Yeah, and this was a proposal that was put together in 2022, and Beck started working on it in October last year. So and also I just want to say, in addition to all of that, it's been lovely to share the working group with Rebecca over these months. Just a very generous, informed, thoughtful presence throughout it all. So yes, over to you, Rebecca.
Thank you very much. I'll just share my screen. Oh, I can't share my screen. Now I can. Okay. Thank you. So hi everybody. Thank you for being here this afternoon. Thank you, Sheena, for that introduction. And thank you all for joining to listen to a briefish talk about my research. I know that research isn't necessarily everyone's cup of tea, but I'm hoping that there'll be something of interest for everyone in these slides, and that we'll have a discussion at the end that brings up some pertinent points. So as Sheena already said, so the title of my PhD research is very relevant to this community of practice group, because essentially it's about mapping the potential for trauma-informed care for people referred to UK palliative care services. Just a couple of things from the outset, though the word UK is in there, and in terms of final implementation and so on, that's what this is looking at. The PhD is very much open to global learning. So I think there's a lot more going on outside the UK than there is at the moment inside the UK. So it's not that this is ignoring all of that, rather the opposite. I really want to learn from international findings. And I know a lot of the members of this community of practice are not based in the UK. And the other thing I just want to say is, as Sheena said, I am a palliative care social worker. This PhD wasn't necessarily supposed to be a social work PhD, but obviously I come from that background and that will influence things. But I don't want at any point for you to think that I think that trauma-informed care is the domain of a social worker. Not at all. But there are some aspects where obviously my experience and my angle is from social work. So just to say that, just to clarify those 2 points from the outset. So a bit about how, why, and how did we get here? So as Sheena said, this PhD was initially proposed by members of the Association of Palliative Care Social Workers and founders of this community of practice, namely Jeanette and Anne, who I'm sure you've heard from before. And then it was accepted by Lancaster University, who advertised it as a studentship. And it was their advert, I suppose, if you want to call it, proposal that I saw, which really caught my attention because it aligned with a lot of the work that and interests that that I was doing in the hospice at the time. So I was very excited. Didn't think I would have any chance, and maybe didn't give it quite enough thought about what a big undertaking it was. But anyway, I am here now. I'm very excited to be. It is quite a big undertaking because it's 3 years and it's full time. As Tina said, I started last October, so suddenly it's going to be a year in. I don't know how that happened, but it did. It's what they call a PhD by publication, which is a slightly different format to your usual PhD. So it will be one big, how big, tome at the end, but that will be made up of self-contained papers, which I will hopefully publish along the way, which will fit together in a lovely thread and story. And create the final piece. So it's a mixed methods PhD, so I get to do a bit of everything. It starts off, I'll go into a bit more detail about this later on, but it starts off with a scoping review, which is a bit like a literature review, but as the name suggests, perhaps a bit wider in scope. I'll then do a quantitative piece of research, which will be an online survey, and then 2 qualitative pieces, which I have yet to define. So it'd be great that'll be one of the things that maybe we can discuss, and it'd be great to get your input on. On this slide, I just realized your faces are covering my, on this slide, just put a few of the key phrases from the advert or the proposal that I first read, because I think they're important to note. The first one is basically just a reminder to me that this is provisional research and I don't need to have or find all the answers. So this is just to keep me calm, I think, at my moments of panic. Yeah, this is really just, it's a starting point, basically. It's a map. The word was in the title, the mapping, to map out what is out there, and then to see from that base where myself or other researchers can go from there, right? The second point I think is very important, because that's one of the reasons I'm here today. My supervisors are really keen that I work closely with relevant organisations such as Community of Practice, such as the Association of Palliative Care Social Workers, maybe as I move through the PhD with policymakers or whoever might be relevant, so that really in shaping this, that it's a collaborative piece of work with practitioners and public advisors. And that really goes to the last point, that the idea is that this is supposed to have impact, and this is supposed to lead to a greater body of work. Okay, so I will try not to spend too much time on this slide, though it's difficult because once you get going, because I think most of, well, you all will know all this already, but just I think it's a reminder of why was this PhD proposed, and why at least I, and I think the people who proposed it, thinks it's important. So a few things that I thought we can all agree on, I think, and are facts. So trauma-informed care, as we know, was a term that sort of came out in the early 2000s from the US, Harris and Fallett. And it's an approach that has been gaining traction across different services in the UK ever since. And we see it appearing more in UK policy papers. You know, there's a lot of work, especially going on in Scotland. I think they're a bit ahead of the game from the rest of us. And more recently, we've seen an increasing number of professionals across the globe advocate for it to be specifically to be applied to palliative care. You'll have seen, I'm sure you've read some of the papers or you've seen the names, you know, we've got De Groot, Gansel, Rixa, Hearn, Brown, those kind of papers that have been floating around. I know Jeanette shares some of them on the community practice as well, which is great. And in these papers, and these experts, their opinion, their arguments for why, you know, this approach is particularly, well, should be applied to palliative care. I think in general, there's an argument that trauma-informed approach is appropriate for any health or care service, or indeed any service, public service that we offer. But then there are some more specifics, right? So one is the epidemiology, I can never say that word, of the palliative care population. So, you know, we're talking about people that have got a life-limiting diagnosis, that have undergone medical trauma, perhaps are of an older age, have, you know, different reasons where there might be more prevalence of trauma in this population, right? And then there's all of our practice experience of seeing the ways that emotional trauma can negatively impact the end of life experience. And if you read these papers, you see a whole list, you know, from increases in perceived pain, in mistrust, in anxiety, in depression, in lack of collaboration with staff. There's lots of things that the literature points to. And then I think if you read those papers, another theme that comes up is a lot of them talk about the sort of natural synergies that exist between trauma-informed care and palliative care, because both are intended at least to be holistic, to be person-centered. The focus is not necessarily on treatment, but on improving symptoms. And I think they've also got in common that they both seek to promote safety, choice, transparency. So there's themes, there's a natural overlap. So that's all great. And we're all like, great, brilliant, trauma-informed palliative care. It sounds fantastic. But the fact is that despite all this support, there is little empirical evidence. And that's not just for trauma-informed palliative care, that's for trauma-informed care in general. I mean, and feel free to debate me with this, but I think, when you read the literature, it's sort of a bit like how much evidence do we have for its actual effectiveness is limited. So we share some of those problems. If we're going to try and get an evidence base for trauma-informed palliative care, we share some of the wider problems, right? Which is that a universal understanding of what does it look like? What are the outcomes that we need to measure its effectiveness? And I think it's important to develop an evidence base, at least and we'll discuss maybe later on to what extent, because if we don't, then I think there is a danger that this approach that so many of us believe in can end up being misinterpreted or watered down or kind of lost amongst some of the many other approaches and aims and objectives that different organizations and policymakers have. So that, I think, in a nutshell, is kind of why we're here, or why I'm here, to try and get this stronger evidence base for this approach that so many of us sort of believe in, right? So you're not expected to be able to read this. In fact, I'm quite glad you can't. But the reason I've put this up here is when I started my PhD, I was trying to, and looking at this, the general question, trying to organize my thoughts, and it just led into all of these different sub questions and so on. And I just wanted to share a little bit with you of my thinking in the beginning, because I think it's important. So I started with sort of two sides. So on the right hand side, you've got the what, right? So what do we mean by trauma-informed palliative care? And even that question starts you off on a rabbit hole, right? As I mentioned before, what is trauma-informed care? There's not necessarily a consensus on that. We have some popular definitions. We've got one that's used by a lot of professionals, is the one from the US Substance Abuse and Mental Health Administration, or SAMHSA. The UK government has a working definition of trauma-informed care, which draws on that, but it's slightly different. And then, of course, different services, different organizations all have their own interpretation. So there's what is trauma-informed care. And then what I hadn't really thought of when I started this, but it's equally important, is what is palliative care? Because, palliative care has moved beyond, has gone upstream and downstream, hasn't it? It's not just end-of-life care anymore. My experience is mostly working in a hospice inpatient unit. So I quite closely associate it with end of life. But of course, you can go all the way to, palliative therapy that starts years before. And then, of course, you've got post-death bereavement and grief. So it's also kind of knowing, what are we talking about when we mean palliative care services, or at least in the context of this PhD, because I have to focus somehow. So there's the what, and then there's the why, right? So why should we even implement this, right? So is there evidence that trauma impacts the end of life experience? What is that evidence? Is there evidence that there is a higher prevalence of trauma amongst this population? And is there evidence that these trauma-informed approaches are actually effective? And once we've got some of those answers to the why and the what, then we can go down to the bottom and start thinking about, okay, so what does a fully conceptualized and validated model of trauma-informed palliative care look like? I doubt there's just one, right? Considering, but to start thinking about what it could look like, at least for different parts of palliative care services. And then how do we implement it? What are the barriers? What are the enablers? The list goes on, right? So suddenly you realize there's a lot of things that need to be answered. And my PhD isn't going to answer all of these. Sort of the bits in the red boxes are where I'm focusing on. And then hopefully after that will be where future research will be able to sort of pick up from that baseline point and go further. Okay, so I want to talk a little bit about research positionality and also philosophy, not in too much detail because I know, like I said, I don't want to give you a lecture. Also, I'm not an expert on any of this yet. I'm just learning. But I think since we're all practitioners, I think research positionality is an interesting one. And I don't want to speak for social work around the world because I know it's a different profession, especially has a different sort of especially in the US and so on, it's seen differently. But I think it's fair to say that in the UK anyway, it is sometimes criticized for its lack of evidence base. So this practitioner researcher role is seen as perhaps quite a good way to fill that gap by having researchers who also have experience in practice. And that has, so that's what I am essentially referred to as by my, and that has pros and cons, right? So the pros are increased accessibility, hopefully, to participants and better understanding of the palliative care system and in particular social work practice and culture. But also it has negatives because I obviously come with my pre-existing views, what I've done and seen in practice. And then I put there inside a bias, and I've put bias in quotation marks because my supervisors told me to be very careful with that word because it's my role and my position is not something that I have to try and like eradicate from the research, right? It just is part of the research. It's something I need to reflect on constantly. So it's not about trying to take out the bias. It's trying to say all the time when I'm making decisions, when I'm thinking about what questions am I trying to answer, how am I asking them, and what conclusions am I drawing? How is my role, my knowledge and my background and my positionality, how is that affecting that? So it's part of the process rather than something that you have to kind of go avoid, if that makes sense. Okay, so, and again, this is not going to be a lecture on research paradigms of philosophy, but I think you might find some of this a bit interesting, I hope. So there are lots, there's a huge, I didn't realize this either before I started my PhD, but there are all these debates about how you should approach research. And, you know, I think there's people whose full-time job is just talking about which is the best, is researching research, if that makes sense. But from what I understand, so I think there's kind of two sides of it, both of two positions, both of which I think I am trying to get towards. So on the one side, as the researcher and as someone who wants this research to have impact, so with policymakers, for example, eventually, there is this desire to produce, you know, reliable, valid, objective evidence, often seen as being numbers and stats and hard facts, right? And that's kind of what we would call a post-positivist approach, right? So there's that one side of me. And then obviously there's a practitioner social work side of me, which is like, well, no, I believe in everyone's views and perspectives and I want to collaborate. And, you know, this is subjective experience is just as important and everyone sees things differently. And that's kind of what I think they would describe as a constructivist standpoint. So you can actually apparently merge both of these. Seems like a bit of a get out of jail free card, but I'm going with it. And call yourself a pragmatist, which is what I'm going to do. And I'm sure it's more complex than just merging them, but for the moment, that's how I'm seeing it. And so obviously we know what the word pragmatist means in everyday English, and it's kind of quite similar. But basically it's saying that, you know, you value subjective and objective experience sort of equally, rather than getting caught up in these debates about, you know, that can sort of consume quantitative versus qualitative researchers that are very ontological and epistemological. And I really like this quote from Lottie because I think it really talks to this project and how it came about. So she says that, you know, a pragmatist sees that knowledge is developed from pre-existing thoughts that evolve into research questions based on problematic experiences. I think that's what we've got here, right? We're practitioners who have seen the problems in practice, and we've come up with we've come up with thoughts, and now my job is to try and see how we can, I guess, turn this knowledge into evidence of more robust nature. And also, I think that this pragmatism approach aligns quite nicely with social work in general, right? So it's very goal orientated. It's about the future. It's not research for research sake. It's like, let's try and make some change. Let's make some impact. So I hope that's what it does. So in terms of my, that was basically the introduction. Now I'm just going to briefly talk you through what I've done so far and what I plan to do. So I said there's going to be 4 papers. So 2 of them are already in progress. So one is this scoping review, which I'll talk a little bit more about in the next slide. And the other is this online survey. The bits that are up for debate are what I'm going to do for the qualitative side of things. So probably I will do some interviews or focus groups with palliative care professionals. The question will be who and what will I ask them? And what will be the particular findings that I'm looking for? Then there's also an option, of course, which I would love to do, which is an interviews and focus groups with patients and families. That is the ideal. However, what I have learnt already is that ethics approval is one really long ride. And having just done my ethics approval for the online survey with professionals and seeing the relative complexity of that, it's really tough to get ethics approval for direct work with patients and families, especially given the population that we're talking about. So I'm still hoping that's what I'm going to do, but I just have to be, mindful. We know how difficult that population is to research for all the obvious reasons, right? Timing and so on, and making sure everything is appropriate. And so we'll see what happens there. And the third idea, which is actually an idea that Anne mentioned to me right at the beginning when we were discussing ideas for the PhD, is a Delphi study with thought leaders. And a Delphi study is it's basically kind of like an iterative process where you get kind of experts in an area to iteratively come to a consensus on perhaps a definition or a set of principles. So that could be something quite interesting if we were trying to better define what is trauma-informed palliative care, and how, I suppose, does it differ or what makes it unique to trauma-informed care in general, because I think there will be some principles that will be slightly different. So Delphi study is another option on the table. So the scoping review, which I said was like this literature review, this is really to kind of try and see what evidence is out there, I suppose, that answers the questions that I was or the arguments that I was mentioned at the beginning when I said the pieces that are out there at the moment by Gansel, De Groot, Rixa Hearn, and so on, which are all advocating for this approach. The reasons that they give. So what evidence do we have around those arguments? So, what evidence do we have about the ways that psychological trauma impacts the end-of-life experience? What are the ways that it's currently being conceptualized in practice and implemented? And then what do we not yet know, which is a lot, probably. So this, as you can see, I like books. So I've quite enjoyed this search strategy part of it, which apparently is quite unusual, but you get to spend a lot of time with the librarians. And I've decided on like 6 databases that I was going to look at to try and get as broad a net, cast as broad a net as possible, I suppose is the right term. And so you get to like use like Boolean operators and stuff to put together all your terms, like palliative plus trauma plus this, and come up with all these different combinations, which I thought was really fun. I've been, because it's a scoping review, I can be quite liberal with what I include. So if you do a literature review, it's normally a bit more like you have to have a very strict kind of criteria for for your empirical studies. But I'm including dissertations and PhDs, for example, in case studies, because I think this is quite new, right? So it's interesting. We want to get the most current stuff. So in order to do that, I think you have to be dissertation PhDs could be another interesting avenue. And I just briefly want to talk about some of the things that I'm going to exclude, and it's not because I want to, it's because I have to focus somehow. And so I have to make some tough decisions. But each of these, you know, are really important areas of research, but they kind of take you into a whole nother little, I call it Rebecca's Well, actually. I was thinking about that book the other day. You know what I mean? To another rabbit hole. So bereavement and grief, for example, of course, that's a huge, important part of palliative care services in the UK, but you could argue they're already kind of quite naturally trauma-informed in some ways. And I think that is a whole other piece of research. Critical care is a really interesting one because obviously people are dying there, a lot of people, and there's a lot of palliative care input there, but at the same time, the goals of the two are different. And there's a lot of research out there that's talking about intensive care units in COVID-19 at the moment and trauma. So I sort of just wanted to park that one as well. Assisted dying and suicide, again, another rabbit hole. And the one that I think that I'm struggling with the most with excluding, and I think it'd be interesting to hear your points of view on this, is the last one. So secondary trauma and compassion fatigue, because I think we know that, you know, trauma-informed care is not just about patients and families, is it? It's also a big part of it is about the practitioner. So secondary trauma is really important. However, again, there's kind of like a whole bulk of research on secondary trauma, and especially again around COVID-19 and burnout and so on, that I think it may take away the focus from what I'm trying to do. So that's just some of my reasoning. So what happened with the results? I had over 3,000 papers that turned up, which I was a bit shocked at. I had to go through them all, not word by word. A lot of them you could just get rid of quite quickly, but still, it took quite a time. I think I'm down to about 50, and maybe I'm not quite there yet, but I think I'm just going to do a second pass to make sure I've included all the ones I want to. Really exciting that some international findings. I mean, there's a lot from the US, as we'd expect, but I've got a paper in there from Japan, quite a few from one researcher in Greece, Jordan. So it has got an international flavor. And in terms of like topics that are coming up, some of them are ones that you would expect, or at least I would expect. Some of them were a bit of a surprise to me. So veterans and PTSD, that's an area that is highly researched, especially, I mean, in the US. One that I think we've started to talk about, we've got a talk coming up maybe, with this group about caring for a parent who harmed you. So that's something that I hadn't really thought about before, but there is some research out there, including a recent PhD about, you know, when the impact of if you've gone through child abuse and then you're then the caregiver for that abuser. So that's something I hadn't thought about before, certainly as a practitioner, when I've seen perhaps caregiver and patient interactions that I've thought seemed difficult, I suppose. I had never even crossed my mind that there could be other reasons like that behind it, I suppose. Then, you know, you've got papers that are looking at particular vulnerable groups, marginalized groups such as refugees, undocumented migrants, the homeless, yes. And then one that I wasn't thinking I'd see anything from, I think there's only one paper, or maybe a couple, is post-traumatic growth, which a concept I've heard about before, but I didn't know it would come up within my search strategy. So that's going to add an interesting angle to things, to see that there's some research suggesting that going through this end of life experience can actually, it has almost a reverse effect on some of the trauma. So we'll see once I delve into those. And then many case studies. So we were talking about this earlier in the project group, that the case studies are a really valuable source of evidence, and it's not, you know, the gold standard of what you may see expect in other fields of research. But I think here there is a lot of learnings from them, and it'll be about finding the common threads and seeing the themes. And then supplemental about abstracts, I'll quickly talk about that. I am nearly done. Is that, if you haven't heard of the term before, so sometimes in journals, they don't print the whole paper, or the paper hasn't been written yet. So they'll print kind of maybe a poster abstract or a conference abstract, or a sort of summary of what the paper will be. But you can't get yet, the full details haven't been released, so to speak, or maybe never will be. But there are quite a few of them that are really on this topic, and they're really recent, you know, from this year, last year. which is really exciting because it means there's lots of research that we don't even know that's about to come out yet. So it will be a case of maybe getting hold of those authors as well and speaking to them to see if I can get early access to some of their results and findings. Okay, so that's the scoping review, and then just a quick overview of the survey. Well, I'm just looking at the time. Yep. Okay. So so once the scoping review is looking at kind of what evidence do we have, which even though there's some good stuff out there, it's still limited, right? I think because we all know a lot of the knowledge around this topic is in practitioners' heads. So I really wanted the first survey to delve into that and to find out, what do palliative care professionals, what do they understand by trauma-informed care, trauma-informed palliative care? How much do they understand it? Sorry, how much do they support? Just said that. How much do they support it? So what do they think are the benefits and the challenges? And how much are they currently doing it? In what ways does their practice currently align with what we may call a trauma-informed approach? And I have chosen to recruit just palliative care social workers from the UK, either past or present. There are reasons for that. Not, again, as I said at the outset, not because I think this is the domain of social workers, not at all. But I think I do think they're one of the key members of the MDT who understand trauma because it's part of their social work training. But there's also two practical reasons. One is that to have a more homogenous subgroup is just better for validity of results rather than having, 10 social workers, 10 counselors, 10 psychologists, 10 doctors, whatever. It does help. And also because recruitment is the most difficult thing with these things. And I'm hoping through channels like this and through the Association of Palliative Care Social Workers that I'm going to have better access to palliative care social workers that I would do maybe other members. So I'm aiming to recruit about 100 to 150, like I said, past or present. And I'll be asking them questions about what I've just really been discussing about, their views, training they have, their views on how they see the impact of trauma, the ways they currently respond to it, what works and doesn't work for them in their practice, and what they really think about the potential for trauma-informed palliative care. And some of the questions that I'm using are taken from some existing trauma-informed scales and surveys. I didn't even know these things existed before I started, but they do. They've been used in other services. They haven't been used in palliative care yet. And so look out for the research advertisement coming soon. It will probably be after the summer because I know we're about to get into silly season. So it'll probably be maybe around September, October. If you are a palliative care social worker or have been or know one, I would love for you to share this. Saying that, I have to make sure, and this is all to do with the ethics approval, it's completely anonymous, so I have nobody, including me, will have any idea who has answered this. So please do not feel any undue pressure to participate. That's so I get the ethics tick. But of course, your support and in disseminating it would be greatly appreciated. And that's pretty much it, really. So the work continues once there's still so much more to answer. Once these two papers are kind of wrapped up, then start looking at the next thing. So thank you very much for listening. I think we're going to go into breakout rooms now. Do you want me to share the questions, Sheena?
That would be wonderful, Rebecca. Thank you.
Thanks, Stephen.
Yeah. So we're going to go out into breakout rooms, and I'll put this in the chat. I'm hoping they will stay there for everyone to see once you're in your breakout rooms, but I'll repeat it just in case. So we're going into breakout rooms and some discussion prompts. So, other things may arise as well, but the questions are: how important is it to establish a stronger evidence base for trauma-informed palliative care? What counts as evidence? What research questions would you hope this PhD answers? What would be useful for your practice? What further research is needed following this PhD? And any other questions for Becks? So we will have small group discussions on that and then come back as a larger group.
Yeah, could I suggest, because I have a sneaky feeling that when you post this in the chat, it won't be visible in the breakout rooms. So if people take a photograph of this on their phone, then, they'll have the questions accessible in the discussion, because we really want to mine your thoughts as much as possible. So, and if somebody could take notes of any answers that you have to these questions, that would be great.
So I think that we're just waiting for the breakout rooms, which will be formed shortly. And whilst that's happening, Rebecca, I just wanted to say thank you so much. I could have listened to that for a lot longer. I know you were trying to squeeze it into 30 minutes, but that to hear the research that you've been looking at in more detail, I'd love to read your scoping review. It just, yeah, it's really important.
I'll hold you to that.
Yeah, no, I really would. I would enjoy that. Yeah.